free medical MP3 from cg4u.net for students. Source: Wikipedia. Addison's disease, also chronic adrenal insufficiency, hypocortisolism, and hypoadrenalism, is a rare, chronic endocrine disorder in which the adrenal glands do not produce sufficient steroid hormones, glucocorticoids, and often mineralocorticoids. It is characterized by a number of relatively non-specific symptoms, such as abdominal pain and weakness, but under certain circumstances, these may progress to Addisonian crisis, a severe illness, which may include very low blood pressure and coma. The condition arises from problems with the adrenal gland, primary adrenal insufficiency, and can be caused by damage by the body's own immune system, certain infections, or various rarer causes. Addison's disease is also known as chronic primary adrenocortical insufficiency, to distinguish it from acute primary adrenocortical insufficiency, most often caused by Waterhouse-Friderichsen. Addison's disease should also be distinguished from secondary and tertiary adrenal insufficiency, which are caused by deficiency of ACTH produced by the pituitary gland and CRH produced by the hypothalamus, respectively. Despite this distinction, Addisonian crisis can happen in all forms of adrenal insufficiency. Addison's disease and other forms of hypoadrenalism are generally diagnosed via blood tests and medical imaging. One treatment involves replacing the absent hormones oral hydrocortisone and fludrocortisone. 2 lifelong, continuous steroid replacement therapy is required, with regular follow-up treatment and monitoring for other health problems. Addison's disease is named after Dr. Thomas Addison, the British physician, who first described the condition in 1849. The adjective Addisonian is used to describe features of the condition, as well as patients suffering from Addison's disease signs and symptoms. The symptoms of Addison's disease develop insidiously, and it may take some time to be recognized. The most common symptoms are fatigue, lightheadedness upon standing or while upright, muscle weakness, fever, weight loss, difficulty in standing up, anxiety, nausea, vomiting, diarrhea, headache, sweating, changes in mood and personality, and joint and muscle pains. Some have marked cravings for salt or salty foods, due to the urinary losses of sodium. Increased tanning may be noted, particularly in sun-exposed areas, as well as darkening of the palmar creases, sites of friction, recent scars, the vermilion border of the lips, and genital skin. This is not encountered in secondary and tertiary hypoadrenalism. 2 clinical signs: the negative feedback loop for glucocorticoids on examination. The following may be noticed: 1 low blood pressure, that falls further when standing. Orthostatic hypotension. Most people with primary Addison's have darkening hyperpigmentation of the skin, including areas not exposed to the sun. Characteristic sites are skin creases, e.g. of the hands, nipple, and the inside of the cheek buccal mucosa. Also, old scars may darken. This occurs because melanocyte-stimulating hormone MSH and adrenocorticotropic hormone ACTH share the same precursor molecule, pro-opiummelanocortin POMC. After production in anterior pituitary gland, POMC gets cleaved into gamma-MSH, ACTH and beta-lipoiropan. The subunit ACTH undergoes further cleavage to produce alpha-MSH, the most important MSH for skin pigmentation. In secondary and tertiary forms of Addison's, skin darkening does not occur. Medical conditions, such as type I diabetes, thyroid disease, Hashimoto's thyroiditis and goiter, and vitiligo often occur together with Addison's, often in the setting of autoimmune polyendocrine syndrome. Hence, symptoms and signs of any of the former conditions may also be present in the individual with Addison's. The occurrence of Addison's disease in someone who also has Hashimoto's thyroiditis is called Schmidt syndrome. Addisonian crisis. An Addisonian crisis or adrenal crisis is a constellation of symptoms that indicate severe adrenal insufficiency. This may be the result of either previously undiagnosed Addison's disease, a disease process suddenly affecting adrenal function such as adrenal hemorrhage, or an intercurrent problem, e.g. infection, trauma in someone known to have Addison's disease. It is a medical emergency and potentially life-threatening situation requiring immediate emergency treatment. Characteristic symptoms are 4 sudden penetrating pain in the legs, lower back or abdomen, severe vomiting and diarrhea, resulting in dehydration, low blood pressure, syncope, loss of consciousness and ability to stand, hypoglycemia, reduced level of blood glucose, confusion, psychosis, slurred speech, severe lethargy, hyponatremia, low sodium level in the blood, hyperkalemia, elevated potassium level in the blood, hypercalcemia, elevated calcium level in the blood, convulsions, fever. Causes of adrenal insufficiency can be grouped by the way they cause the adrenals to produce insufficient cortisol. These are adrenal dysgenesis, their gland has not formed adequately during development; impaired steroidogenesis, their gland is present, but is biochemically unable to produce cortisol; or adrenal destruction, disease processes leading to the gland being damaged. 1. Adrenal dysgenesis. All causes in this category are genetic, and generally very rare. These include mutations to the SF1 transcription factor, congenital adrenal hypoplasia (CAH), due to DAX1 gene mutations, and mutations to the ACTH receptor gene or related genes, such as in the AAA or Grove syndrome. DAX1 mutations may cluster in a syndrome with glycerol kinase deficiency with a number of other symptoms, when DAX1 is deleted together with a number of other genes. 1. Impaired steroidogenesis. To form cortisol, the adrenal gland requires cholesterol, which is then converted biochemically into steroid hormones. Interruptions in the delivery of cholesterol include Smith-Liopat syndrome and abetalipoproteinemia. Of the synthesis problems, congenital adrenal hyperplasia is the most common in various forms: 21-hydroxyl-A, 17-hydroxyl-A, 11-hydroxyl-A and 3-hydroxysteroid dehydrogenase, lipoid CAH, due to deficiency of star and mitochondrial DNA mutations. 1. Some medications interfere with steroid synthesis enzymes, e.g. ketoconazole, while others accelerate the normal breakdown of hormones by the liver, e.g. rifampicin, phenytoin. 1. Adrenal destruction. Autoimmune adrenalitis is the most common cause of Addison's disease in the industrialized world. Autoimmune destruction of the adrenal cortex is caused by an immune reaction against the enzyme 21-hydroxyl-A, a phenomenon first described in 1992. 5. This may be isolated or in the context of autoimmune polyendocrine syndrome, APS type 1 or 2, in which other hormone-producing organs, such as the thyroid and pancreas, may also be affected. 6. Diagnosis. Suggestive features. Routine investigations may show 1. Hypercalcemia, hypoglycemia, low blood sugar, worse in children due to loss of glucocorticoids, glucogenic effects, hyponatremia, low blood sodium levels, due to the kidney's inability to excrete free water in the absence of sufficient cortisol, and also the effect of corticotropin-releasing hormone to stimulate secretion of ADH. That hyponatremia occurs even in secondary adrenal insufficiency, i.e. due to pituitary disease, in which aldosterone deficiency is not a feature, underscores the fact that hyponatremia in Addison's disease is not due to lack of aldosterone. Hyperkalemia, raised blood potassium levels, due to loss of production of the hormone aldosterone. Eosinophilia and lymphocytosis, increased number of eosinophiles or lymphocytes, 2 types of white blood cells. Metabolic acidosis, increased blood acidity, also is due to loss of the hormone aldosterone, because sodium reabsorption in the distal tubule is linked with acid hydrogen ion H+ secretion. Low levels of aldosterone stimulation of the renal distal tubule leads to sodium wasting in the urine and H+ retention in the serum. Treatment. Maintenance treatment for Addison's disease involves replacing the missing cortisol, sometimes in the form of hydrocortisone tablets, or prednisone tablets, in a dosing regimen that mimics the physiological concentrations of cortisol. Alternatively, 1/4 as much prednisolone may be used for equal glucocorticoid effect as hydrocortisone. Treatment must usually be continued for life. In addition, many patients require fludrocortisone as replacement for the missing aldosterone. Caution must be exercised when persons with Addison's disease become unwell with infection, have surgery or other trauma, or become pregnant. In such instances, their replacement glucocorticoids, whether in the form of hydrocortisone, prednisone, prednisolone, or other equivalent, often must be increased. Inability to take oral medication may prompt hospital's admission to receive steroids intravenously. People with Addison's are often advised to carry information on MEG, in the form of a medic alert bracelet for the attention of emergency medical services personnel, who might need to attend to their needs. At a crisis, standard therapy involves intravenous injections of glucocorticoids and large volumes of intravenous saline solution with dextrose glucose. This treatment usually brings rapid improvement. When the patient can take fluids and medications by mouth, the amount of glucocorticoids is decreased until a maintenance dose is reached. If aldosterone is deficient, maintenance therapy also includes oral doses of fludrocortisone acetate.